Let's review the two commonly used anticoagulants, EDTA and heparin. Anticoagulants are agents that prevent blood from clotting, each working by a different mechanism. EDTA stands for ethylenediamine tetraacetate. Its mechanism of action is to chelate calcium ions. Since calcium is an essential factor in the coagulation cascade, binding it prevents clotting from taking place. This makes EDTA widely used in hematology, especially for complete blood counts, because it preserves cell morphology. Heparin works differently. It acts as an antithrombin agent. Specifically, it enhances the activity of antithrombin 3, which inhibits thrombin and other clotting factors. By doing so, heparin prevents the conversion of fibrinogen into fibrin, effectively stopping clot formation. Heparin is commonly used in plasma chemistry testing and in clinical settings where rapid anticoagulation is required. Let's review the key points about hemoglobin testing. Hemoglobin is a critical measurement in hematology, reflecting the oxygen-carrying capacity of blood. The principle of hemoglobin measurement involves oxidizing hemoglobin to methemoglobin. Traditionally, this is done using potassium cyanide and potassium ferrocyanide. An alternative method uses sodium lauryl sulfate, which is safer because it avoids cyanide reagents. Certain factors may interfere with hemoglobin measurement. Lipemia or icterus can cause turbidity, falsely elevating results. A high white blood cell count may also interfere with accurate readings. Resistant hemoglobins, such as hemoglobin SS or CC, can give misleading values because they do not react fully with the reagents. Slide 4. Reference ranges. Normal hemoglobin ranges differ between males and females. For males, the reference range is approximately 16 grams per deciliter, plus or minus 2. For females, the range is approximately 14 grams per deciliter, plus or minus 2. In summary, hemoglobin measurement relies on chemical oxidation, but accuracy depends on recognizing sources of error and applying the correct reference ranges. Now let's summarize the important hemoglobin variants that affect oxygen transport in laboratory testing. Methemoglobin. In methemoglobin, the normal ferrous iron, Fe2+, in hemoglobin is oxidized to ferric iron, Fe3+. This change prevents hemoglobin from binding oxygen effectively. Methemoglobin gives blood a brownish color and leads to reduced oxygen delivery to tissues. Carboxyhemoglobin. Carboxyhemoglobin is formed when hemoglobin binds to carbon monoxide instead of oxygen. It is significantly increased in carbon monoxide poisoning and in smokers. It gives blood a characteristic cherry red appearance, which is sometimes seen clinically. Sulfhemoglobin. Sulfhemoglobin is unique because it is the only hemoglobin not measured by the cyan-methemoglobin method, which is the common laboratory technique for hemoglobin determination. It results from exposure to certain drugs or chemicals, and it causes a greenish discoloration of the blood. In summary, methemoglobin cannot bind oxygen brown color. Carboxyhemoglobin, carbon monoxide binding cherry red color. Sulfhemoglobin, not measurable by cyan-methemoglobin method. Let's review Hematocrit, an essential laboratory measurement. In principle, Hematocrit measures the packed cell volume, expressed as the percentage of blood volume that is occupied by red blood cells. The microhematocrit method can be performed using blood from a fingerstick or from samples collected in EDTA or heparinized tubes. Sources of error include failure to seal the capillary tube adequately, incorrect readings caused by an uneven clay plug, inappropriate centrifuge time or speed, excess EDTA, which can cause red blood cell shrinkage. In automated hematology analyzers, hematocrit is calculated rather than directly measured. It is derived from the mean corpuscular volume and the red blood cell count. Sources of error include cold agglutinins, which alter red cell measurements, a very high white blood cell count, which can falsely elevate results. For males, the reference range is approximately 47%, plus or minus 5. For females, the reference range is approximately 42%, plus or minus 5. In summary, hematocrit can be measured manually or automatically, but both methods have potential sources of error that must be recognized for accurate results. Let's review the process of performing manual cell counts for white blood cells and platelets. Manual cell counts are performed using a dilution technique. The purpose is to obtain an accurate measurement of white blood cells and platelets when automated methods are not available or when verification is needed. The diluent used is 1.98 milliliters of 1% ammonium oxalate solution. Ammonium oxalate lyses red blood cells while leaving white blood cells and platelets intact, making them easier to count. Using a micropipette, measure 0.02 milliliters, or 20 microliters, of the blood sample. Add this to the diluent to create a total of 2.00 milliliters. This produces a 1:100 dilution, which is appropriate for counting white blood cells and platelets using a hemocytometer. Let's review the structure of the hemocytometer counting chamber, a tool used for manual cell counts. The chamber is a square grid, measuring 3 millimeters by 3 millimeters, and it is divided into 9 large squares. Each large square measures 1 millimeter by 1 millimeter. The central square is itself subdivided into smaller grids. This is the primary counting area for white blood cells and platelets, depending on the dilution and procedure used. The chamber has a fixed depth of 0.1 millimeter, established by the specialized cover slip placed on top. This ensures that a precise volume of sample is counted. By knowing the area of the counting grid and the chamber depth, the exact volume being observed is calculated. This allows the laboratory professional to determine cell concentration in the original blood sample after accounting for any dilution performed. This is the calculation formula used in manual cell counts performed with a hemocytometer. The formula is number of cells counted times reciprocal of total volume times dilution factor. The number of cells counted is the raw number of cells observed in the defined counting squares under the microscope. The total volume is the known volume of fluid over the counting area, which is determined by the chamber dimensions. The formula uses the reciprocal, meaning 1 divided by the total volume. If the blood sample was diluted before loading into the chamber, the dilution factor corrects the calculation back to the original cell concentration in the patient's blood. In summary, this formula converts raw counts into a standardized cell concentration, typically expressed as cells per microliter or cells per liter of blood. Furthermore, the volume of one hemocytometer square is calculated as length times width times depth. The total volume is the volume of one square multiplied by the number of squares counted. For white blood cell count, all 9 large squares are used. Each square has a depth of 0.1 millimeter. Therefore, the total volume counted is 1 millimeter times 1 millimeter times 0.1 millimeter times 9 equals 0.9 cubic millimeters. For platelet counts, all 25 small squares within the central large square are used. The volume of this area is 1 millimeter times 1 millimeter times 0.1 millimeter equals 0.1 cubic millimeters. In summary, white blood cells are counted across 9 large squares, while platelets are counted in the central square. The reference ranges help identify normal versus abnormal results in clinical practice. Let's walk through the red cell indices, which are key parameters in hematology for classifying anemias and other red cell disorders. For the mean corpuscular volume, MCV, the formula is hematocrit divided by red blood cell count, multiplied by 10. The normal reference range is 80 to 100 femtoliters. A value less than 80 indicates microcytosis, while a value greater than 100 indicates macrocytosis. For the mean corpuscular hemoglobin, MCH, the formula is hemoglobin divided by red blood cell count, multiplied by 10. The normal range is 28 to 32 picograms. The result varies with hemoglobin content and cell size but is less diagnostically specific than MCV and MCHC. For the mean corpuscular hemoglobin concentration, MCHC, the formula is hemoglobin divided by hematocrit, multiplied by 100. The normal range is 32 to 36 grams per deciliter. A value less than 32 indicates hypochromia, often seen in iron deficiency. A value greater than 36 suggests conditions like spherocytosis or interferences such as leukemia, icterus, or the presence of certain hemoglobins such as hemoglobin SS or CC. For the red cell distribution width, coefficient of variation. The formula is the standard deviation of MCV divided by mean MCV multiplied by 100. The normal range is 11.5 to 14.5%. A value above 14.5 indicates anisocytosis, meaning variable red blood cell sizes. For the red cell distribution width, standard deviation. This is the measured width of the red cell volume distribution curve at 20% of its height. The normal range is 39 to 47 femtoliters. A value greater than 47 also reflects anisocytosis. In summary, MCV classifies cells as microcytic or macrocytic. MCHC reflects hemoglobin concentration, identifying hypochromic or hyperchromic conditions. RDW indicates variation in cell size or anisocytosis.